for this academic event. You all know that we are conducting this type of webinar twice in a month, especially on different academic subjects. And really, I am very much happy that our physiatrist friends from overseas, from Bangladesh, they have also joined. Really, we welcome to this platform to all the physiatrists of Bangladesh. And I hope this webinar will be helpful for the participants. So today we have an interesting talk on evaluation of treatment of cerebral palsy. As you know, cerebral palsy is a multiple disability conditions. So it affects multiple systems of the body, starting from cognition, vision, hearing, then locomotor problem. Though we most of the time we focus on locomotor problem, there are also some other issues where a physiatrist can identify. So we treat cerebral palsy children as a whole, including the locomotor and other aspect. Today we have with us Dr. Eluri Rajendra Kumar. He is a quite senior person in this field. He has done his MBBS from Siddharth Medical College, Vijayawada, and he has done his B also from a prestigious organization, that is Manipal Academy of Higher Education, and he has done his DNB from another prestigious organization, that is CMC Vellore. Currently, he is working as Associate Professor and HOD, Department of PM&R, ESIC Medical College, Hyderabad. So, over to Rajendra sir. Hope your discussion will enlighten different aspect of cerebral palsy management, especially for the physiatrist person. Over to you, sir. Thank you.
Thank you, sir, for giving me this opportunity. Actually, sorry for the delay because I had some emergency. I was stuck in a surgery, so it was late. Sorry. I will start my presentation, sir.
Thank you.
Sir, actually, sir, you have given a good introduction about me. Thank you for your introduction. Actually, I got passionate with physical medicine rehabilitation, where I work, that is in CMC Vellore, where it was a good department was there. My boss, Dr. Suranjan Bhattacharya, many regards to him because he has taken care very well of us, and he taught us so many things which I have never learned in my life also. So it was a very good experience in CMC Vellore for me. After that, after Vellore, I joined in an institute called Nizam Institute of Medical Sciences, that is in Hyderabad. But I tried to establish a department, but it was not successful. Then I was started my private practice. I was very happy in my private practice. Suddenly, one doctor by name Dr. Srinivas, who is the present director of AIMS, he wanted to start a department in ESI Medical College, where he used to work 6 months ago. So he called me immediately and asked me, Dr. Garu, can you start a department of physical medicine rehabilitation? Where I joined. And now, actually, with all your wishes and this one, we got 5 PG seats also in this NEET. We got 5 MD-PMR also. So we have a very good cardiopulmonary rehabilitation. I think one of its best in India also, I can say. We have a good cardiopulmonary rehabilitation exercises, equipment, and program. With short introduction, I'll start my topic. As you know, rehabilitation is utilization of existing capacities of handicapped persons with the combined and coordinated use of medical, social, education, vocational measures to the optimal level of functional ability. Next is the goal of any rehabilitation is to maximize the function and minimize the disability and handicap resulting from underlying disease or impairment. As we all know, we have 3 things. One is called impairment, disability, and handicap. Impairment occurs at the organ level, disability occurs at the individual level, and handicap at the societal level. So, as we all know about all these things, next I'll go to this upper motor neuron and the lower motor neuron differences. We all know this one. Whenever we have an injury to brain and spinal injury, we have an upper motor neuron lesion. When we have an injury to plexus and peripheral nerves, we have a low motor neuron lesion. So coming to the actual topic. One is it is divided into I have divided with one is developmental sequences, gait, spasticity, range of motion, assessment of strength, and functional evaluation. Whenever we are assessing a cerebral palsy child, we should know the development sequences of the child. Like any child, after birth, they'll get a motor milestone like neck control, rolling, sitting, kneeling, standing, and walking. Without this sequence, no child can walk. So if a child presented with 6 years, where he doesn't have a kneeling, he can't walk. So our main focus should be on the this developmental sequence. Like what I want to tell you is, see, this one is developmental, say 4-point kneeling. This is a 4-point kneeling. First, he should get this one. Then he should get sitting. This is called a high sitting. This is a long leg sitting. This is a cross leg sitting, and yet this is a W sitting. So W sitting should not be encouraged for the patient. Next is, this is the kneeling. The kneeling is a very important step in motor milestone. If you doesn't have a kneeling, patient can't stand and patient can't independently without kneeling. So kneeling is a very important step. If you have a kneeling, that indicates that he is having a good trunk control. Next, coming to the spasticity. This is a very important topic. Spasticity is a disorder characterized by velocity-dependent increasing tonic stretch reflexes and exaggerated tendon jerks, resulting from hyperexcitability of stretch reflex. Advantages of spasticity are mainly it helps in standing and walking, it maintains muscle mass and bone mineralization, reduces dependent edema in limbs, decreases risk of deep vein thrombosis. These are the disadvantages. Mainly, it interferes in activities of daily living. It interferes in positioning. It interferes in personal hygiene. It causes disturbed sleep. Long-term spasticity causes contractures. These are the factors which aggravate spasticity, that is urinary tract infections, pressure ulcers, contractures, release of tightly wrapped leg backs, tight garments, fecal impaction, heterotopic ossification. These all generally occurs in generalized spasticity. I'm not telling about the cerebral palsy child. These are the factors aggravates in spasticity. As spasticity is measured by Ashworth scale, modified Ashworth scale. 0 is no increase in tone. 1 is slight increase in tone manifested by a catch with minimal resistance at the end of ROM. 1 plus is manifested by catch resistant throughout the range of motion. 2 is marked resistant throughout the ROM. 3 is passive movement difficult. 4 is affected part is in rigid inflection or extension. The main objective whenever we are treating spasticity is to reduce the deforming force on account of spasticity with the help of various interventions to allow better functions and to prevent secondary complications. As you know, these are the general types of gait we see, that is in-toeing gait, scissoring at hip, knee hyperextension, and ankle plantar flexion. As we know that most of the children that like in cerebral palsy, where they present with in-toeing gait. Generally, in-toeing gait occurs when the patient has having W sitting. If you have a W sitting, this in-toeing gait, the patient will present with the in-toeing gait. So how to correct this in-toeing gait is make them to sit in a cross-leg sitting and stretch the tensor fascia lata muscle. Then the in-toeing gait will decrease. Next gait is scissoring at hip. Scissoring at hip generally occurs when you have a adductor spasticity. When we have an adductor spasticity, most of the patient presents with scissoring at hip. And coming to knee hyperextension, mainly if the residents are there, they should remember the knee hyperextension occurs mainly due to 4 causes. First cause is if you have a quadriceps weakness. If you have a quadriceps weakness, you have a knee hyperextension. Next is if you have a quadriceps spasticity and contraction, you have a knee hyperextension. And the third one is, the very important thing is, if a patient is present with the equinus at ankle, they present with knee hyperextension. And the last one is, if there is any injury back of the posterior part of the knee joint, that is capsule, injury to the capsule, there will be a knee hyperextension. Coming to the ankle plantar flexion, the commonest gait we see in cerebral palsy is ankle plantar flexion. That is, if the hyperextension of the there will be a spastic gastrocnemius. So for the resident's sake, I'm telling the spastic the muscles which crosses two joint will go for spasticity. Generally, the muscles which crosses two joints will go for spasticity. Some exceptions are there, then, but these are the muscles which crosses two joints go mainly go for spasticity. You see this gait. We operated day before yesterday. This patient he is having a hemiplegia with equinus at ankle and knee flexion and little bit adduction and flexion deformity at the hip. Then comes to how to assess the spasticity, and any muscle which has a spasticity, it will go for contracture also. So this modified Tardieu scale helps in determining spasticity and contracture. So how the modified this Tardieu scale measures is, see this. Please see in this video. So the first is velocity dependent increasing tonic stress reflex. So with immediate this one, they will have we got a 90 degrees this one. But if we are doing very slowly, it is almost going into 140, 150 degrees this one. So the first moment, what that is 90 degrees, what we call first is called as R1. And the second moment until what it is going is R2, that is a 120 or 130 degrees. If R2 minus R1 is more, then the spasticity component is more. If R2 minus R1 is less, then the contracture component is more. So this is how we differentiate spasticity and contracture. Next, you see here also. The first moment there is a spasticity. Then I have done very fast. Then when we are doing very slow, it is the range is more. So R2 minus R1 is more, means there is a spasticity component is more in this child compared to the contracture part, because spasticity component is more. Next, the main goals in management of cerebral palsy is to decrease complications due to cerebral palsy and to enhance or improve the acquisition of new skills. These are the options for interventions in spasticity. One is intrathecal baclofen form, removing noxious stimuli and chemical neurolytic agents, orthopedic and neurological interventions, oral drugs, chemodenervination with botulinum toxin. I'll just tell oral drugs. Generally, what we use oral drugs is mainly baclofen, diazepam, and apart from sometimes we use tizanidine and other drugs also, but baclofen and diazepam are the two common drugs we use for decreasing the spasticity. And coming to next, what the indications of peripheral nerve blocks are mainly, if there is a severe spasticity, it should be a complementary to physiotherapy to improve motor control. Is a focal spasticity in cerebral palsy, higher age group, unable to afford high expenses, and to relieve pain and discomfort. This small video is there, how I am doing my peripheral nerve adductor block, that is obturator nerve block we are doing in a local anesthetic. With after giving local anesthetic, we are just giving a now we are stimulating a this wire we are stimulating with the electrical stimulator. So you can appreciate some contractions also here. You can appreciate some contractions here. You see some contractions of the adductor muscles are there. Then what we do is we'll decrease the electrical stimulation. If it is when we decrease the electrical stimulation with the decreased one with maximal stimulus, then it is a then at that time we'll increase. You see this girl who when she has come, she presented with a flexion deformity at ankle, knee, hip, and this one after giving injections.
Sorry,
and,
sir. The slide. Previous slide, please, sir. Previous slide, please, sir.
This one will come one more time also. I'll show you another time also it will come. Then after that we have given a aboni this one. Then we got a standing balance. After getting standing balance, what we do is then we put after removal of cast, we'll put a splints. That is knee splints to prevent flexion deformity and hyperextension, and we'll make them walk with a walker. When they are able to walk with walker, then small crutch we'll train them, and after that we'll without a crutch we'll train them. Next, indications for motor point blocks are mainly I does a phenol injections a lot. In my practice, almost weekly 3-4 times I give phenol, because phenol I only prepare myself phenol, and apart from that one I did my dissertation on phenol in CMC Vellore, where we have done gait analysis after giving phenol blocks also. So my passion is for phenol. So botulinum toxin also we give, but affordable patients we give. That is, these are the common indications I follow. That is, any age group phenol can be given. It is very affordable. It is not affordable. It is very affordable and no time constants. And in botulinum toxin, we give an younger age group, because as age grows, they need a more units of botulinum toxin, and it is costly, and time constant is there. Then come to baclofen pump. When I was working in NIMS from 2002 to 2008, we have put baclofen pumps for cerebral palsy children also. But in our experience, it's not that much helpful for the patients, because selection of the patient is also very important. And apart from selection of the patients, how they manage with the pump is also very important. Then what we done is one research we have done. One is, it is called selective motor fasciculotomy. That is, there is a thesis also, one neurosurgery PG has done with this. We published this article also. That is, we expose the sciatic nerve, and when the sciatic nerve, after exposing sciatic nerve, when the sciatic nerve giving branches to the muscles, at the muscle end, we cut that nerve with stimulator after stimulating it. So what happens is, there will be a spasticity will be decreased to that muscle. So after that one, if the patient is having contractures to the hamstring also, we'll do a fractional lengthening or tenotomy of the semitendinosus muscle. So this is an we published an article on sciatic SMF. We call it a selective motor fasciculotomy and hamstring lengthening. You see this same video, we have published one more article on phenol block, that is on all traumatic and non-traumatic brain injury patients, and traumatic and non-traumatic spinal cord injury patients, not in cerebral palsy, but in all patients who is having a spinal cord injury and traumatic brain injury, including cerebral palsy patients. This article also be published after this one. And I want to just share few surgical this one. Just you see this video. This girl, 6-year-old girl, she's having an equinus of the right right foot, right ankle, and now you see after surgical intervention, she has come with the plantigrade foot. She needs some strengthening exercises, but the deformity has been decreased. And we do after TL lengthening also, we do the small seamless procedure if plantar fascia is tight. You see this patient, she's having a little bit awkward gait. She's also a cerebral palsy child with minimal awkward gait. Lot of spasticity component is more than the contracture component. Next, what we have done further here is the selective motor fasciculotomy of optitator nerve and tibial nerve. He is going into a little bit hyperextension, mainly because of the TA contracture. Thank you. Thank you, sir.
Thank you very much, Dr. Rajendra. So the forum is open for a questionnaire. If any question from audience, please put into the chat box so that we'll discuss on different questions. In addition to the present interesting talk that he has shown some clinical videos also, which are very much interesting. And the main theme is that how you approach cerebral palsy, how different intervention procedures improves the gait pattern of the CP is the discussion for today. So whenever any child is coming to OPD, normally we ask the parents how the child is working, what is the upper limb function, what is the limb function, whether the child is able to grasp a working aid or not. And if the child is working with the help of the parents, so please don't jump for any intervention or any orthosis straight away. We have to look for the proximal part control, that is the trunk control and hip control. Dr. Rajendra beautifully discussed about the kneeling test. That's a very important test to know the what is the ambulation potential of the child. If the child is having a very good kneel standing, that clears that the child is having a good or fair trunk control and hip control. Those two things are very important for any distal part surgical intervention or anything. So before jumping into any procedure on the distal part, say around the knee or on foot and ankle, please ensure that the hip control is fair enough, the trunk control is fair enough. The child should have a good long sitting balance, starting a dynamic both balance. So these are the minimum prerequisites for jumping into any intervention to the distal part. And the best test is ask the child to go for kneel standing or kneel walking. If the child is having a kneel standing in and fair kneel walking, that's the best standard for intervention, and certainly the child will improve at least 1 or 2 level of GMXS. That is about kneeling test, and he discussed about entowing gait. Sir, I would like to add something into the entowing gait, that besides the discussed problems of the in CP with entowing gait, many times we observe that the medial group of hamstrings and adductors also contribute to the entowing gait. So when we examine a child working with an entowing gait or a seizure gait, so we have to differentiate whether this entowing or seizuring gait is because of a adductor spasm or it is a medial hamstring, or sometimes iliopsoas spasticity also can give rise to some amount of seizuring. So there is a described Flaps test is there, which differentiate whether the pathologies are the adductor level, pathologies are the iliopsoas level, or pathologies are the medial hamstring. And accordingly, we should intervene to reduce the entowing gait and seizuring gait. And there are two more important gaits also, like Kraus gait and Zompney gait.
Yes, sorry, I missed
these
it.
things,
I missed it.
yes, these things are actually becoming late part of the child. When the child started walking the equinus gait, gradually there will be midfoot break as the child put on weight because of limited ambulation. They gradually develops this Kraus gait. They started with a Zompney gait where there is a equinus at the ankle joint, and hip flexion and knee extension. And they turn to Kraus when there is a excessive dorsiflexion at the ankle joint, hip flexion and knee flexion. They become established this Kraus gait, which is really difficult to managed. So these are the two other important gates which are seen in late age, say towards adolescent or after 10-12 years age group. And rest of the things beautiful discuss, sir. To discuss something about selective motor control. So can you focus something about that? How do you select the selective hyper excitable nerve roots, selectively cut those roots only to control spasticity?
Sir, actually, we have an electrical stimulator. So after, see, generally we are doing for a motor nerve roots only. That sensory part, generally we are not touching that one. That is, suppose if we are taking an obturator now, it is a purely motor nerve. Most of the time it is a motor nerve, and we are stimulating the nerve when it is entering into the muscle. We'll expose the muscle when the nerve is entering into the muscle. We'll cut at that part, so that there won't be any sensory problem at that one. Suppose if you are one surgery here, one doctor by name Dr. Purohit is very famous for selective posterior rhizotomy. He does selective posterior rhizotomy a lot, but there are some advantages for it. Minimal disadvantages are also for it. But here in fasciculotomy, what we are doing is we are exposing the nerve and exposing the muscle nerve root when it is entering into the muscle. So we'll cut that muscle and we coagulate that one. So that see this procedure also Dr. Purohit does a lot. I used to assist him when I was in Nizam Institute of Medical Sciences. We have done a lot of camps with that one. We had a good results. Actually, sir, it should be a complementary to everything. Suppose if he does only selective posterior rhizotomy without casting, there is no use. Suppose if he does a selective motor fasciculotomy to tibial nerve, that is when it is entering to the gastrocnemius. And see, in my view, sir, any muscle which is having spasticity, it has a contracture also. Contracture part also it has some component of contracture component. So if he does a spasticity component is being decreased, this contracture part component can be decreased with the help of casting. Suppose if it is a fully contracted, then we can go for surgical intervention, the lengthening of the tendon.
Yes. How often you come across with this complication of femur like muscle necrosis? Anything? Do you have come across such type of complication, muscle necrosis with femur use?
So I feel it is a myth, sir. I am giving since more than 2 decades. More than 2 decades. I give not only this peripheral nerve blocks, I give a motor point blocks. How we give botulinum toxin, we give like that to the with phenol, 6% phenol in water. I give a lot, but I didn't find any this one. When I was working in Nizam Institute of Medical Sciences, one muscle we have given phenol, and one muscle we have given botulinum toxin, and they underwent for surgery, and I have not seen any muscle necrosis. We haven't seen nothing. It was but I personally feel, I think if it is a strength of the phenol is more, it may go for a muscle necrosis, I think.
Okay. Do you apply it for the upper limb spasticity also? Phenol?
Yes, actually, generally it's a very common thing we use for biceps, pronators, wrist flexors, and finger flexors. These are the very common muscles we give phenol to this muscle, sir.
Interesting, sir. Can you explain briefly about how you prepare phenol? This is for the juniors, that how you prepare. You are not getting your concentrated phenol.
Yes, sir. We get phenol crystals are available, sir. Phenol crystals are available. That will become solution. So what we do is 3 ml of that solution we'll put in a jar. 3 ml of and we put 50 ml of distilled water.
Okay.
So it will become 6% phenol in water.
Okay, presuming that the initial concentration is 100%. Yes,
yes, that is yes, sir. Yes, sir.
Okay.
And there is no, see, sir, I personally feel since more than 2 decades I am doing this one, I didn't get any muscle necrosis. And apart from that one, after giving phenol, most of the patients I put the cast also, sir, to correct the contracture part.
So we'll take some questions. Let me see in the chat box.
Sir,
Okay.
Sir, can I ask please, sir?
Yes, please.
In case of using of phenol in children, will we dilute the phenol for reduction of spasticity or contracture?
Yes, sir. We can.
Sir, for using phenol
Yes, sir.
in reduction of spasticity or contracture,
Yes, sir.
should we dilute the phenol with normal saline in case
No,
of
that's
child?
what I'm saying, sir. While preparing the phenol, what we should is 3 ml of aqueous phenol should be taken, and with that we should mix it with 50 ml of distilled water. So it will become 6% phenol in water.
3 ml phenol and 15 ml normal
50,
saline.
15, 50, sir. 50 ml.
50, sir. Okay, sir.
50 ml. Then only it will become
50,
6%
okay.
phenol in water, sir.
Yes, sir. Okay. Sir, result of phenol in case of spasticity removal, sir, is it excellent?
Very with spasticity, definitely, sir. Most of we see, sir, most of the motor point blocks. I told you I does know. So most of the patients will decrease spasticity within few hours only, sir.
So, in what point we should application phenol in the muscle, within the muscle or at the site of the nerve? Phenol?
Sir, which is suppose if you are planning for a gastrocnemius muscle, so you make them to
Yes, sir.
lie in prone position, and from proplital crease, 3-finger breadth, you just put one or two needles on the muscle, gastrocnemius muscle, and flex the ankle and see whether that needles are moving. Like what we does in botulinum toxin, we see that whether that needle is moving. If that needle is moving, generally that will be in a motor point block of a gastrocnemius. We can inject in that point.
Yes, sir. Thank you, sir.
Yeah, there is one more question. How do you manage crouch gait? Do you
What,
have
sir?
an how do you manage crouch gait? There is a question.
Yes, sir. Crouch gait, we have done one research also, sir. That is, we have a crouch gait. See, in crouch gait, what happens? There will be a flexion deformity at the knee, and what happens is dorsiflexion at the ankle and flexion at the knee joint.
Okay.
So most of the time, there will crouch gait, hamstring spasticity and contracture mainly contributes to the crouch gait. So what we can do is we can give a phenol to the hamstrings, and we can put a cast and make them get a balance. Or what we can, we have done a research, that is a study. What I have showed, we have done a selective motor fasciculotomy to the sciatic nerve. That is exposing the sciatic nerve when the small branch entering into the hamstring muscles. We have cut that one. Then after that one, we have put a cast. Or if suppose a contracture is more, then we have done a lengthening of the muscles. That is generally what we does for hamstrings is we does fractional lengthening to semimembranosis and biceps femoris, and tenotomy to semitendinosis.
Can I add something to this, sir?
Yes, sir. Please, sir. Please.
Okay. So basically, if you go to the answer to the crouch gait, there is one way of conservative management, I mean minimal invasive method to manage crouch, which is well explained by Dr. Rajendra Kumar. But other ways also, if you look to the pathology of the crouch gait, you will have hip flexion, knee flexion, and ankle dorsiflexion, which suggests that there is the hip extensor has poor in poor control, and there is excessive spasticity or tightness or contracture at the knee flexors, and the plantar flexors are weak. So the most of the time the plantar flexors are weak because of arthrogenic injury. When we go for a inadvertent TA lengthening for a child which is less than 8 years age group, they are likely to develop this weakness of the gastrocnemius, and moreover, other ways, one deformity leads to other. So this ankle dorsiflexion leads to knee flexion and leads to hip flexion. So if you you will try to correct biomechanically, you have to strengthen the hip extensors, and at the same time also you have to strengthen knee extensors and relax the knee flexors. So the procedures we follow in our organization is reducing spasticity by transferring the bijoint muscles, that is semitendinosus, to adductor tubercle, so that the bijoint muscle became a unijoint muscle. The semitendinosus, which was offending structure causing knee flexion, became a assisted structure for helping extension of the hip, because it is now a unijoint muscle that is crossing across hip only. So by taking out the semitendinosus to adductor tubercle, otherwise called a Sutherland's procedure, which helps in augmenting hip extensor, at the same time also removing the offending structure which was causing knee flexion. At the same time also, we can go for fractional lengthening of the semimembranosus if the spasticity of the knee flexors are still there. This is how we manage. And for foot management, often managed by AFO. So you stabilize the knee, and you can augment also quadricep by there is a shortening of the ligamentum patelli. We augment the quadricep so that the quadricep power is increased. We augment hip extensor by transferring semity to the adductor tubercle. So one by one, stabilize hip, stabilize knee, and most of the times the ankle is managed by orthostic. This is how we manage crouch gait in our institute.
Excellent, sir.
One more question. Sir, how to manage intoing if it is because of increased femoral anteversion? You can.
I think you should answer that one, sir.
See, again, if it is femoral anteversion, it is there. There is a derotational osteotomy is required, but it is not done always unless it is not corrected by the medial hamstring lengthening. So, if by lengthening medial hamstring by fractional lengthening or a adductor correction of the adduction contracture, if the intoing is still significant, then someone may require a derotational osteotomy. For me, in my 20 years practice, I have never done this derotational osteotomy. But in the book, it is written that it is possible beyond 8 years age group, when there is severe intoing, in spite of releasing adductors, in spite of releasing medial hamstring, and there is also other procedures by transfer of iliotibial band to medial side. That also helps in correcting the intoing gait. So if all these soft tissue procedures are failed, then one can go for subtrochanteric derotational osteotomy for correcting the intoing gait.
Sir, I want to share something I want to add for that one.
Yes,
sir,
yes, please.
If the patient is below 5 years of age, you see him, he's having intoing gait. My suggestion for that one is make them to sit in a cross-leg sitting and cross-leg sitting, and make them to touch their knee joint to the ground. So that what happens is there will be a small stretching of the lateral flexors of the hip, that is a TFL muscle, or will also get stretched. So, and there will be an improving in the intoing also. Avoid cross-leg, avoid W sitting, and stretching of the TFL. This also helps in decreasing the intoing, apart from surgical this one.
Oh, good suggestion, sir. This should be well taken by everybody. The simplest procedure by a therapeutic maneuver, one can try to avoid this intoing gait. Somebody has suggested that it's better to transfer a medial hamstring to distal femur instead of tenotomy. Yes, we have already discussed that. Is there any deadline? How much of phenol we have to use in large muscle or small muscle like buttocks?
Sir, actually, we can use from what I am following is from suppose gastrocnemius you want to use for a 4 years child. What I'll take is 4 motor points I'll take in the gastrocnemius, and I give 0.5 ml, 0.5 ml, 0.5 ml. We can give this one. There is no, as what I have followed is there is no standardized that this much only should give, but exercise, see, do less if it is harmful. That's my way of thinking. And if it is a bigger muscle, I can give 1 ml also.
Okay, sir. Interesting. Actually, few of us have that type of exposure of putting phenol. Many of us are using Botox injection, which is very costly. If it really
most of the patients are not affordable, sir.
We are very much afraid of that putting phenol into the muscle may lead to muscle necrosis. This type of worriness, we are always trying to avoid phenol injection. It's interesting from your side that you have so much experience on putting phenol into the muscles.
Yes, sir. Motor muscles doesn't happen, sir. As I told you, when I was working in NIMS, we exposed both sides and we didn't see any necrosis of the muscles also.
Okay, thank you very much, sir. Any question or any suggestion from participant side? Dr. Taslim from Dhaka, do you have any suggestion in this? Hello. Okay, so that means there is no more questions in the chat box, and if there is no suggestion, no queries from participant side, then we can wind up the session. So thank you very much, Dr. Rajendra Kumar. Really, you have enlightened us regarding phenol use, very interesting thing. And I hope all my colleagues, my friends, all physiatrists, all participants will certainly get benefit out of it. The worriness for us that phenol causing so much of necrosis, I think you have removed that worriness from our mind. We can try with phenol also. So thank you very much. And I must thank all the participants, all my friends from overseas, from Dhaka. They have joined us, they have shared their views. Thank you very much. And I would like to thank the PR team of IA PM&R, those who constantly helped us for uploading this webinar to in the YouTube channel, so that the friends who have not attended this webinar, they can go through the YouTube. And I must thank all my friends from my department, all the office bearers of Odisha Association of PM&R for encouraging us conducting such webinars. I hope that this webinar will continue with new chapters, with new techniques and new speakers in future. Thank you. Thank you very much.
Sir, I should thank Abhishek, sir. Actually, he was very instrumental in asking me for, sir, can you present this session? Actually, I am in a private practice since more than 15 years, sir. Suddenly, just 6 months back only, I joined academic institution. But Abhishek was very much enthusiastic, sir. You present something. I should thank him for giving opportunity to meet all of you in the webinar, sir. Thank you, sir.
Okay, I will convey the message to Abhishek. Thank you. Thank you very much. So we'll wind up. Good night. Good night, everybody.
Good night, sir.